male fertility. Male fertility occurs in about 40% of cases of infertility. That's the official word. But it's important to remember that at least 25% of couples will have both male and female factor infertility, and it does currently take both an egg and a sperm and a uterus in order to make a baby. So male fertility, there's not a lot known about male fertility. It's kind of crazy, but the primary test for male fertility is really just to look at the sperm under the microscope, and we've been doing that apparently for hundreds of years. So we really haven't advanced a lot in hundreds of years in terms of analysis and diagnosis of male fertility. So we know how to count them, look at motility percentage. So we look at concentration. You have you take the volume. What is the normal volume? Normal volume is about 2 millimeters, 2 to 5 millimeters of ejaculate. And then we look at them under the microscope. They're spread out on a little slide with a grid so we can calculate the concentration. Normal concentration is 20 million sperm, total sperm, per milliliter. The percentage that are moving, because everybody's got some in the ejaculate, some dead sperm and some moving sperm, some good looking sperm and some yucky looking sperm, that's normal. So 50% should be moving. And then there's usually always a measure of forward progression. We typically use a scale from 0 to 4. So 0 is like they're dead. They're just not moving at all. Or 4 is like a rocket ship. 2 is normal. 2 and above is normal. So that's like medium. They're moving around. They're doing a good job. So that's your basic semen analysis. And if you have normal parameters, if you have like a good concentration and good motility and they're moving forward pretty well, then most likely you're in good shape. Now, there's a lot of other more subtle things to do. A really common thing that we see is morphology. And 2 common scales are the WHO and the Kruger scales. The important thing to remember is morphology is extremely subjective. It's the andrologist, or the person in the lab who's looking at the sperm, looking at the shape of the sperm under the microscope. Do they look handsome and normal and symmetric the way they're supposed to, or are they like funky looking? Do they have like double heads or double tails or weirdly shaped tails or weirdly shaped heads or things like that? So that's morphology. And we do believe that if somebody has a lot or mostly severely abnormal sperm, it could be an issue in terms of being able to fertilize an egg. But we don't understand it really well, because when you look at some of the studies, people that have poor morphology and have normal counts and motilities, the morphology doesn't seem to matter as much. So morphology, we believe, is much less important than the basics of count and motility. And then there's anti-sperm antibodies. That's another common test, and what we're looking is for proteins in the sperm that bind to the sperm head, the midpiece, or the tail. Because if you have proteins coating the sperm, could possibly affect motility, possibly cover the cap of the sperm, which has to attach to the egg, and though that could be a cause for infertility. That's not very common at all, but that could be a cause for infertility. We also wash the sperm and put it through processing as if we're going to be doing IVF or IUI. IVF is in vitro fertilization, where we put the sperm and the egg together in the lab, and IUI is intrauterine insemination, where we wash the sperm and put it into the woman's uterus at the time of egg release. So we have to wash the sperm, we have to get rid of this dead sperm, the poorly shaped sperm, and the actual semen, because the semen is just fluid that carries the sperm out of the testicles and out of the penis to be able to deliver it to the vagina. So that's not necessary to go into the uterus, and in fact contains a lot of chemicals that could cause a lot of cramping. So that's why we remove it for IUI and for IVF. So once you remove it, and look at the amount of sperm you recover, that's another measure of the health and the function of the sperm. And we often like to, for an IUI prep, we often like to recover a total motile count of 5 million or more, because what we find is, what the studies say is that if you have 5 million motile sperm recovered, or you have 50 million motile sperm recovered, you still have the same IUI pregnancy rate. Whereas if you have between 1 and 5 million sperm recovered in this IUI washing process, and you do IUI, the IUI pregnancy rates are lower if all other factors are equal. If you consistently can only recover less than 1 million sperm for an IUI prep, those patients often just don't conceive with IUI and often need to do IVF with ICSI. ICSI, or intracytoplasmic sperm injection, which is a very successful IVF treatment where we actually take a single sperm and inject it into the egg at the time of IVF in order to normalize fertilization. And that procedure has been around since the 1990s and has almost eradicated male factor infertility. You know, if you can do IVF, then even if you have very low counts, your pregnancy rates can be the same as people with normal counts. So that's a short summary of semen analysis. Hope that was helpful. Take care.